So now I'll fill in the blanks a little bit, but that's what I hope you're going to remember from this. Psychiatry's at a crossroads right now because we're a little bit in limbo. We know enough to know where things are heading, but we know also enough to know that we're nowhere near where we need to be. We know enough to know that this is a medical specialty that we need to have empirical diagnosis and empirical treatment and empirical science-based protocols in terms of what we're doing, but we don't have them yet, for the most part. We treat patients based on what works. You could call that empirical, but it's not based on the basic science that underlies most other medical specialties. We can't do a culture yet and find a bug that tells us, okay, this is the antibiotic you need to take. We can't do an EKG yet that is going to show you what the abnormality in the rhythm is so that you know exactly what is it that you're treating. And we can't, even like in neurology, you can't even do, even though in certain sense you can, but it's not the same. We can't find a focal neurological lesion that will tell you what's going on there, and in the case of neurology, hopefully be able to treat it, even though most of what they're doing is not really treatable. We're sort of the opposite. We can treat a lot of things, but we don't know what we're treating. That's the truth. We are still functioning in our specialty a little bit like doctors used to function probably about 100 years ago, when they were basing their diagnosis on clusters of symptoms. So in the most basic way to understand it, even though it doesn't have to be that way, if you have a cough and a runny nose and a fever, chances are you have a cold. Nobody's going to order a $5,000 battery of tests to diagnose the common cold. If you have a suspicion that it might be the flu, then maybe you'll run a culture, which we can do today, but for the most part, you're not going to do that. You'll just tell the patient the proverbial take 2 aspirins and call me in the morning if somebody has a cold. But that's the way in psychiatry we're functioning for the most part. Now, it works. It works for, I would say, probably somewhere between 60 and 80% of patients, it works. We can figure out, in general terms, what is it that this patient is suffering from. We can be extremely accurate at diagnosing certain things. There were studies done probably about 15, 20 years ago that showed that the accuracy of psychiatrists diagnosing depression based on DSM-4 at the time was far greater than the accuracy of cardiologists diagnosing an EKG by looking at it. Far greater, I mean, incomparably better. So we are very good at diagnosing and knowing what people have in general terms. And we've gotten to a point where we're pretty good at treating most patients. Most patients get better and get significantly better. Even I would say that most patients get completely better. But because we don't have the underlying basic science to be far more accurate than we are, and to tailor our treatments far more than we are, a lot of patients are falling through the cracks because those are patients that do not fit the classical syndromes and that perhaps are a little bit atypical, and they don't respond to medication the same way most people do. So there's a significant number of patients that are not getting better, that we're not being able to help the way we would. And we do still help them more than we used to. Nobody at this point is being locked up for life in a psychiatric facility. That doesn't exist anymore. An average psychiatric hospitalization today is somewhere around 7 to 10 days. And that's a long one already. It used to be, when I was a first-year resident in 1994, and I got to Cornell, the Westchester facility. Cornell Hospital has a very large psychiatric facility up in White Plains. That's where I trained, and that's where I started my professional career after. It's about a 350-bed hospital, purely psychiatric, all the specialties, inpatient, outpatient also. I remember that as a first-year resident, I still had patients that had been there for 10, 15 years. when I started treating them. And they were the last few that were left. Today, that doesn't exist. That doesn't exist. It used to be, and you probably can see these buildings, they're all over. I don't know if here in Brooklyn there still are some, but all over the country there were this state psychiatric hospitals, right? You guys are probably going to remember. State psychiatric hospitals were huge hospitals with thousands of beds where patients would be confined for life, literally, because there was nothing to do. So what did you do? I mean, these were people that had a manic break, had a psychotic break, had a severe disabling depression, and there was nothing to do. There were no medications 50 years ago. There was nothing. There were wetbacks, restraints, and perhaps for the lucky few, an horribly primitive form of electrical shock treatment that was depicted quite colorfully in that famous movie One Flew Over the Cuckoo's Nest. So in the late 80s, certainly there were medications started before. In the 50s and 60s, Thorazine already existed, and lithium came around in the 60s, but nobody knew how to use it. And ECT got much modernized, but really it was in the early 90s and on that modern psychiatry started in strength, with the advent of the DSM-4 that unified psychiatric diagnosis and that helped us be able to communicate, so that when somebody said depression, we were all talking about the same thing. When somebody said OCD, we were all talking about the same thing. And again, we still didn't and still don't have the scientific underpinnings for all these things, but at least we could use a common language. And at that point, this amazing new medications started coming out, like Prozac and Zoloft, that are incredibly well tolerated and extremely effective. And all of a sudden, within 10 years, all these huge hospitals with thousands of patients living there were all empty. There was nobody there because everybody had gotten better and had gone home. It was a ridiculous thing. People that were literally living in a psychiatric institution for life, and then they would get a medication, and a couple of weeks later, they were a normal person.
Well, we also have to factor in how the states were emptying the institutions.
They were emptying the institutions because they didn't need them anymore. People were normal.
Also, there was all movement to get rid of mental health.
That's the reason for the
A
movement.
lot of the people were still
That people were better, that people were getting
better.
better and they could go home. They didn't need to live in a psychiatric facility. They weren't letting out people that were sick. They weren't letting out psychotic people. They were letting out people because they were getting better. And they were normal and they could go home. The fact that those people after would stop their medication and get sick again and become revolving, that's a different story. Access to outpatient mental health, we can talk about that, but that's not the topic of what we're talking about tonight. The fact is that people would take their medication, take a couple of pills, become a normal person, and they would go home. And all these buildings are still abandoned buildings all over the country. They're still there. Look like ghost towns. And that's when the revolution started. That's when psychiatry started becoming what it is today, which is a regular medical specialty. Psychiatric illness is brain illness, okay? And we're still stuck with this diagnostical categories that are based on clusters of symptoms, even though people are starting to work on a different approach. There's an amazing project going on at the NIMH today, the Research Domain Criteria project, where they're pouring millions and millions of dollars on a completely different way of thinking. What they're trying to do is they're trying to identify the exact brain circuits that have to do with the different symptoms, not with the different illnesses, because that's not possible. So they're trying to find where exactly in the brain does paranoia happen, where exactly in the brain does the main symptom of depression, which is anhedonia, which is the incapacity to feel pleasure, and that takes away your drive and your motivation and your interest. Where is that circuit located in the brain? Where is the circuit that makes somebody become hyper and grandiose and hyper-religious in the case of a manic patient? They're trying to find those specific circuits in the brain. Everything in the brain is circuits, it's not areas, circuits that interconnect different areas of the brain. They're trying to identify the exact circuitry that's behind, and then try to see in each specific type of patient as we know them today, let's say what we call today depression, let's try to see which of the circuits are involved in this. And what's going to happen is that, and with that, they're trying to do away with the names that we have today for these conditions, which suck. The names that we have are horrible. Like, take the name depression, for example. This is horribly confusing. It's horribly confusing. Because it comes from hundreds of years ago when people thought that what we call today depression, being sad and down, that had gotten out of control. So this person didn't know how to regulate their emotions. This person had some kind of psychological or emotional weakness that didn't allow them to control their sadness, and that's how they ended up here. So oftentimes patients are profoundly depressed and don't feel sad or down at all. In fact, they don't feel anything. And so I tell them, well, I think that you're suffering from depression. I tell them, no, I'm not. Why not? Because I'm not depressed. I say, you're right. You are not depressed. You're not depressed in the feeling sense of depressed. You are depressed in the sense of a clinical depression. So that's a very simple example of how these names that come from so long ago are horribly confusing, and because they don't mean anything. So this group at the NIMH is trying to do away with all this, and is trying to come up with new concepts, new names, new constructs of how brain psychiatric illness is diagnosed, is thought about, and then be able to target these different abnormalities in brain functioning, looking for new treatments that are going to be targeted to that. If and when that happens, which probably will happen within the next 20 years or so, that's going to be when we're going to be able to send a patient that comes into the office for a functional MRI or a certain type of PET scan, and that's going to tell me exactly what this patient is suffering from. And we're going to discover, because we know it in clinical practice, that when we talk about major depression, it's really probably 4 to 6 different subversions of what we call depression today. And we're going to have whatever the name of the condition is going to be by then, but it's going to be depression subtype A, B, C, or D, and that's going to be able to tell me exactly which type of medication is the right one for this patient or not. That's the direction that we're heading to, and there's a lot happening, and we're seeing a lot of movement in that direction. There was a study out of a group in Atlanta that came out, I think it was about 6 months ago, that used functional MRI. Functional MRI, for those who don't know, is there's a neuroradiologist here, so I'm stepping into his territory. So functional MRI is basically an MRI. Everybody knows what an MRI is. MRI shows you the structures in the brain in a very, very clear way, almost like a picture. But a functional MRI adds to that a certain markers that you can inject in the bloodstream that go up to the brain and that can light up which areas of the brain are functioning more or less or missing, etc., etc. So you can superimpose a picture of the anatomy of that area with knowing what is happening there in terms of how is it functioning. And with that's been the largest revolution in psychiatry probably in the last 20 years, that we've been able to use functional MRIs to see which areas of the brain are involved in different things. I'll talk more about that in a second, but this study out of Atlanta about 6 months ago, what they did was truly revolutionary. They used functional MRI not only to diagnose major depression, which they did with about an 80+% accuracy, but looking at those functional MRIs with different computer algorithms, they were able to identify which patients would benefit more from medication and which patients would benefit more from psychotherapy. And they treated the patients, and lo and behold, they were exactly right. It was a double-blind, randomized trial, and it proved that the functional MRI with the computer algorithm was able to diagnose and identify the type of treatment that these patients would benefit the most from. So that's the direction that we're heading. Also, we're heading in the direction of genetics. they're trying to find the genetic underpinnings of all this. But again, the problem that has been getting in the way of us being able to use genetics in the way that we need to is this old-fashioned diagnostic system that doesn't really work properly. So that you can't really find the genetics of major depression, for example, or bipolar disorder, for example, because there's so many, not so many, but there's several different types of depression. There's several different types of bipolar. And they are probably lying in a spectrum of disorders. And so to figure out the genetics behind them is almost impossible. So they've been able to identify genes here, there, and everywhere. And of course, for each condition, there's not one gene. We're talking about clusters of genes. But so the approach of the NIMH is a much better approach because they have been able to identify, for example, a couple of genes that determine the predisposition to develop paranoid ideation, right? So patients that all of a sudden, when they get sick, they think that the FBI is after them, and that there's satellites spying on them, and that there's agents running after them to get them. One patient that I have that is, so this poor guy, he has schizophrenia, which is probably the single most severe and less treatable illness in psychiatry. And this guy is convinced that the Mossad was after him, and has all kinds of proofs of why the Mossad and what the Mossad was doing to mess with him, et cetera, et cetera. And then I treated him, and the Mossad was not after him anymore. So it turns out that this guy had been writing compulsively emails and letters and all kinds of things to the Prime Minister's office in Israel. They probably knew him by then. And when he got better with the medication and he didn't think that the Mossad was after him anymore, I asked him, so no, why do you think the Mossad is not after you anymore? He said, no, because the Prime Minister read my email. so that's a cute story. But what they have been able to identify is the gene that predisposes the patient to paranoia. Because what's interesting about paranoia, for example, is that paranoid ideation can be a symptom of many different illnesses, right? Because psychosis in psychiatry, which is the loss of reality testing, right? When the stimuli that's coming from inside my brain stops being differentiated from the stimuli that's coming from outside my brain, right? We all have the capacity to separate what's coming from in here from what's coming from out there, and we have a brain system that's in charge of doing that, right? It tells me that bottle is something that is outside of me, and I'm looking at it, and therefore it's an objective reality, okay? My own image of a bottle in my head, well, that's my own image of a bottle in my head. They're not the same, right? They might be very similar, but they're not the same. So in psychosis, the capacity to differentiate from what's coming from the outside and what's coming from the inside is lost, right? So the ideas that are coming from inside my head, the stimuli, the images, the thoughts, the storylines, the sounds are perceived as if they were an objective reality coming from the outside. So, and psychosis is not a psychiatric diagnosis per se. Psychosis is a symptom of severity in psychiatry. So virtually any psychiatric illness can develop psychotic symptoms if it's severe enough. Like schizophrenics, by definition, that's their illness. They become psychotic when they're not well, but that's not the only symptom. There are plenty of symptoms in schizophrenia when they're not psychotic, but a patient with clinical depression, if they're severely depressed enough, they will become psychotic, and they will have delusions, paranoia included. A patient with mania, the opposite of depression, can become psychotic. A patient with OCD can become psychotic, okay, if it's severe enough. So going back to the story about genetics, they were able to identify the gene that codes, or the genes that code for paranoia, and they were able to see that there were patients with depression, with bipolar, with schizophrenia that were carrying that gene. And that those were the patients that have the potential of becoming psychotic if the illness becomes severe enough. So lo and behold, not any patient with depression can potentially become psychotic no matter how severe their illness is. and so on, so on and so forth. So by looking at brain circuits and how they function, we're going to be able to identify the genetic underpinnings of all these different things. And we've been able to, going back to functional MRIs, we've been able to see where in the brain different psychiatric symptoms happen. For example, we have been able to see that one of the symptoms of particularly psychosis in schizophrenia is auditory hallucinations, right? Hearing voices. They hear voices. And they actually hear voices, okay? And the voices usually are telling them horrible things and insulting them and threatening them, and they're horribly scary for these patients. And with functional MRIs, we've been able to see how in those patients, when they are hearing voices, the auditory processing areas in the brain are lighting up. So they are, but the auditory stimuli receptor areas in the brain, meaning the areas that receive the stimuli coming through the ear into the brain, are not lighting up. But the areas of the brain that are processing sounds are lighting up. So somehow these people are actually hearing sounds that are not coming from the outside, right? Same happens with visual hallucinations. We see the visual areas of the brain lighting up, but not the areas that receive visual stimuli from the eyes are not lighting up. So those are some examples of where we see different things. So we have seen there was a study, a classical study, one of the studies that started this whole brain image revolution, and we're talking about probably 1996. It was a PET scan study, not a functional MRI study, that showed different areas in the basal ganglia of the brain, and how in patients with OCD, this obsessive compulsive disorder, and that's where we know that OCD is in the basal ganglia of the brain, and we were able to see how the basal ganglia was highly overactive in patients with OCD. And then the study took randomized two groups of patients to either Prozac or CBT, cognitive behavioral therapy for OCD, which is a highly effective form of psychotherapy for obsessive compulsive disorder. And what the study showed is that after 6 weeks of either one, the abnormalities in the basal ganglia were equally resolved. So both Prozac and CBT were working the same. The difference was that the effect of Prozac was more longer lasting. The effect of the CBT eventually faded, as long as the patient kept on taking the medication, of course. So I could keep going on and on, but the point I was trying to make at the beginning, this is the so this is the derech rechoka to get to the point that I'm trying to make, which is that psychiatric illness is a medical problem. It's not a psychological problem, it's not an emotional problem, it's not a spiritual problem, any more than high blood pressure is a spiritual problem or a psychological problem. And people tell me, well, but when I'm stressed out, then I feel anxious or I get depressed. So yes, people with Crohn's disease flare up when they're stressed out. And people with high blood pressure, the blood pressure shoots up when they're stressed out. What? That means that Crohn's disease is a psychological illness? No. Any illness, any physical illness that a person has is going to flare up under stress. Stress attacks the entire body, and it's going to flare up. If somebody has a psychiatric illness, guess what? The brain is highly sensitive to stress, and it's going to flare up, whatever condition you have. That doesn't make it into a psychological problem, and it definitely doesn't make it into a spiritual problem, which is a problem that I often have. It's a medical problem, like any other medical problem. Just like your kishkas can get sick, just like your lungs can get sick, just like your heart can get sick, guess what? Your brain can also, unfortunately, get sick. It's just so that the brain is in charge of controlling a bunch of things like feelings and emotions and thoughts and motivation and sleep and appetite. And those are the symptoms that are affected in psychiatric illness. So that it's a little bit confusing for the person that is not well informed and educated in this area. It's a little confusing that perhaps the way I'm feeling right now is not because I am feeling that particular way, is because my brain is having a short circuit right now that is causing me to feel angry, sad, anxious, scared, or you name it. It's not me, it's my condition. But that's the way it is. The fact that I am seeing my entire life under such a black veil right now is not because my life is so dark, and it's not because I am such a terrible person. It is because my brain is acting up, and it's painting everything of this black color. Perfect example. I've had this twice actually. CEOs from big Wall Street companies that come to see me in the middle of a severe episode of depression, and both guys actually, incredibly enough, told me that they can't keep working where they're working. Their work is making them miserable, and their lives are horrible, and nothing is good, and it's stressing them out. I need to quit my job. I need to quit my job. It's too much pressure. I'm overwhelmed. I cannot do it. I need to quit my job. And both guys, I told them, that's fine. Maybe it is, maybe it isn't. We don't know. I just ask you one thing. Let me treat you for 2 months. And if in 2 months you still feel, and your depression clears, and you still feel that your job sucks and that you want to quit, gesundheit. But give me 2 months, and let's see what happens. And both guys, both got better completely. With very simple medication. And they came back 2 months later, loving their jobs, loving their lives, and being better at it than ever. So one of them actually I just saw a couple of weeks ago, and he just retired, but this is 20 years after that story, 15 years after that story. And he retired for good reasons. His mother was sick, he wanted to take care of her, he has plenty of money to go around, he wanted to teach, he wanted to travel, so no, he retired. But he retired for a positive reason. He retired because he wanted to retire, because there were things that he wanted to do with his life, not because his life was so dark and miserable and he hated everything, including his job. That was the difference. So this time I didn't try to dissuade him. And I think he's quite happy. Unfortunately, because this modern psychiatry that I'm talking about, that we're on the verge of becoming, and that we are in many ways already, is very, very young. I don't know how many other medical specialties are as young as medical psychiatry is. So most people have been exposed to the idea of psychiatry from 60, 70, 80 years ago. There was this mostly psychological construct that all psychiatric problems were emotional problems, psychological problems, or even sometimes spiritual problems. And on top of that, a psychological movement that, especially in America, was heavily influenced by Freud and Freud's followers, who were of the death of Jews, basically all of them. I mean, I think that there were 1 or 2 goyim that they had in the bunch, but everybody else was a Jew, and all of them were masculine. So one of Freud's, of course, who was a very smart guy, and when you read what he wrote and the way his followers learned what he wrote, and there were brilliant things that he said, but they learned it literally like one would learn Gemara. It's quite amazing. I was in the Psychoanalytic Institute. I'm trained as a psychoanalytic therapist, and when you're going to classes there and they're reading Freud texts, they're literally touching the words and almost the nikud, and he said this word and he said it this way and didn't say it that way, so it means it's literally like you're learning Gemara. It's a crazy thing, and they don't realize. But the problem was that one of Freud's points was to try to say that religion was nothing but a psychological symptom, and that being a religious person and believing in God is because you had this conflict with your father and this conflict with your father and the other conflict with your father. So that, of course, in a time when the Jewish world, the Orthodox Jewish world, was fighting the Haskalah in a very, very strong way, and they were terrified of losing more people because they were losing people in droves before the war in Europe. Then they became very weary of Freud, even though there's some stories, and I don't know if they're true or not, I think it was the Rebbe and Freud. It didn't happen. I don't know the details, but
There's a transcript of it.
yeah, there's a transcript. Okay, I would love to see it. So in Jewish circles, people were extremely wary of Freudian therapy, and by extension of any kind of therapy, and by extension of any kind of going to psychiatrists and trying to treat psychiatric illness, because they weren't treating it medically. They were doing psychotherapy, and psychotherapy that could be easily distorted and biased. And if you're saying that you are actually going to be telling people that being a religious person means that you have a psychological conflict and that you need to resolve it so you can free yourself from the load of God and religion, yeah, I can see why Rabbanim would have a problem with people going to therapy. But that's not the way it is anymore, of course. But yeah, so people are still with that image, and the older the generations, the more. But still, the Jewish world is particularly slow at changing, for good reason. It's a very good thing that it's so slow at changing. But sometimes it can create some problems along the way, some growing things. And that's where we are at in terms of mental health. It's changed tremendously. And I would dare to say that in the last 10 years, the view of psychiatric illness has become much more open, and that there's much more openness to access mental health. Almost in every edition of all the Frum magazines like Mishpacha and Bina and all of those, and Amodia and all of them, there's some article about some kind of mental illness and the treatment, and encouraging people to seek help. And people are, more and more openly. Somebody was telling me the other day that actually nowadays group therapy is becoming less and less of a problem. It used to be that it was impossible to have a group because nobody wanted to be seen. And not only that, but now there are groups forming of families, which is something that has existed in the world for many, many years. It's called multi-family groups, and they are psychoeducational groups for families and relatives of people with mental illness that help families learn how to cope with their relatives' illness and how to manage it better, and that works very well for certain more severe forms of illness, like bipolar disorder or borderline personality disorder. And now there are multi-family groups forming in the Frum community because people are less scared of the stigma of mental illness. People are much more open to it and to get the help that they need. So thank God for that. People are realizing it, but not less and less, but still most of the time when I diagnose a patient with an illness and I tell them, okay, listen, you need to take medicine and this is the medicine you need to take, it's like a stab in the heart for people. It's like they feel that they fail. If the parents are sitting there, they feel that they failed. What did we do wrong? What could we have done to prevent this? Are they going to have to take medicine for life? Questions that they wouldn't be asking if Laleno, they were being diagnosed with Crohn's disease. So it's happening less and less, but I find that with every new patient that I get, and oftentimes with follow-up patients too, half of the time I spend it educating people and understanding that this is a medical problem. You have a medical problem. You don't have a psychological problem. Oh, so why are you sending me to therapy? Well, because therapy is an integral tool that we use to treat mental illness. The fact that it's a medical problem doesn't mean that there aren't other non-medication based tools that can be extremely helpful. Like the example that I gave you before, certain techniques in CBT for OCD are extremely powerful. And most patients with an anxiety disorder that I diagnose, I refer to therapy, inevitably. Not everything is treatable with therapy, but there are things that any anxiety disorder, like OCD or panic disorder, without therapy, the patient is 80% of the time, they're not going to get 100% better. But with therapy, they can. So the best example that I use is the example of orthopedic surgery and injuries. Right? A person breaks the leg, and they need to have the legs fixed, and then they need to go to therapy. They need to go to physical therapy to recover full function of that limb. Somebody who has open heart surgery is going to have to go through physical therapy for a while. So why is it so shocking that there's such a thing as psychotherapy? okay, to rehabilitate certain functions of the mind that are impaired by psychiatric illness. And of course, in most of those cases, not all, but most of those cases, they're going to need to be on medication combined with the therapy. Both together, that's the best results. There are some milder cases, and there are certain things that we can't really treat with medication. And oftentimes I see people and I tell them, listen, there's nothing that I can do for you with medication. You need to go to therapy, especially certain types of personality disorders that are not really treatable with medication at this point. And I tell them there's nothing we can do. So here's the phone number for a therapist. This is the right guy for you. Call them and work on it. It can get better, but not with medication. So you don't need to see me anymore. Because I think that if we change, if we all, especially as medical professionals, if we change our view of mental illness, of psychiatric illness, and we understand that this is just a medical problem like any other medical problem, and these are highly treatable medical problems for the most part, even though we're in the infancy of understanding how this works and understanding the nuances of psychiatric diagnosis, and we're going to become far more effective at treating this in the next 10, 20 years. But even at the stage that we're now, we are more effective at treating most psychiatric illness than many other medical specialties are at treating their patients. The vast majority of patients in psychiatry can get 100% better and have 100% normal, healthy, productive, happy lives with medication, maybe, for the most part, but not necessarily, but that's not the point, and that's what I try to tell my patients. What does it matter if you're going to have a 100% normal, healthy, happy, productive life, like anybody else out there, and the price for that is to take a couple of pills every night is not a good deal? I think it's an amazing deal, considering what we said before, that 50 years ago, these people were living in psychiatric institutions, and now they take a pill and it's all gone, completely gone. Completely gone, 100% for life. I think it's an amazing thing. And for me, I'm completely inspired every time it happens. And it happens, Baruch Hashem, every day that I see a patient that I started on medication 6 weeks ago, and they're coming for a follow-up today, and they look at me and they're happy and they're fine, and the anxiety's gone, and they're functional, and they're ladies taking care of their children, and cooking and cleaning and preparing for Pesach happily. And I'm a little bit shocked every single time it happens, but it gives me chizuk, and it renews my I say, oh, that's why I'm doing this. So education is an enormously important thing, and there are many medical professionals out there around the corner here. Dr. Eli Rosen is one of them. He's amazing. He understands this, and he's very ready to give me a call and send people over whenever something's going on. He has no problems. We'll work together. He does the blood tests for me when I need to follow up with the medication. I need to check them, and he reassures people because he understands. And Baruch Hashem, there's a lot of people like that. But I think that all medical professionals today should be informed, because remember one thing: the statistics are that about 1/3 of the patients in any general medical office are there for psychiatric reasons. Okay, 1/3, and the other 2/3 are everything else. In a dermatology consult, about 1/3 of the patients are there for psychiatric reasons. And I found that general practitioners are extremely good at diagnosing the basic conditions of psychiatry, and not only that, they're extremely accurate at figuring out which medication to give. And in virtually 100% of cases, they give about a quarter of the effective dose of the medication. So that a couple of months later, I get a patient in my office that has been on Zoloft for the past 2 or 3 months and tells me, I'm not getting better. And I've been taking Zoloft for 3 months and I'm not getting better. So I look at it and says, no, you're not taking Zoloft. No, yeah, I'm taking Zoloft. Yeah, you're taking 25 milligrams of Zoloft. You need to be taking 150 milligrams of Zoloft if you're going to get better. So people need to, all medical professionals need to educate themselves and understand and stop being scared of this stuff, because so many patients that do not need to come see me or anybody like me, can be treated in any general medical office. Just do it effectively. So don't be scared, be aggressive about treating them. But more than that, be a good educator, to explain to people what they have and to reassure them that what they have is perfectly normal, that is a perfectly common medical condition, just as common and as treatable as having, much more treatable probably than having Crohn's disease or high blood pressure, and certainly than diabetes. So that's my message for today that I had prepared. And I don't want to go over the time, so I want to leave time for questions.
So I just want to say there's a couple things. Number one, for the Gedalia side, we also want to learn and know about the intersection between halacha and psychiatry. Like, what type of questions do you think can come up with psychiatric illness that you deal with, be it young at the time or whatever it is, and the other thing is specific issues within the frum community that you may see aside from the stigma part of it.
I don't think that there are specific, there's a second question, I think that there are specific psychiatric issues that belong in the frum community versus the rest of the world. I think that we have just about the same incidence of every psychiatric illness that everybody else has. I think that perhaps that there's slightly different presentation sometimes, like in OCD, the presentation is going to be with frumkeit and halacha. That's where one of the few areas where halachic issues do become an issue, because patients become obsessed with things that are not halacha, that are obsessions, right? So so a guy can wash his hands compulsively over and over again because they're getting rid of tuma. There's no tuma, you already wash your hands, but they feel that the hands they keep on washing and washing and washing. I have, you want to hear an extreme example? I have a patient that is so terrified of chametz that, not anymore, thank God, but the husband and the children used to have to stop at the door, get undressed, take off their shoes, get dressed with new clean clothes before they entered the house, because she was terrified that they were bringing chametz from outside the house. This is year-round, not on Pesach. Okay? And she would make the children eat in the bathtub if they were eating chametz. That's an extreme example. And if you don't have an understanding, ladies that can take 5-6 hours to prepare to go to the mikveh and still be convinced when they come out that they are not clean, because maybe there was something. So those are extreme examples, and there's everything in between, of course. And that's where knowing what is halacha and what isn't can help the clinician, right? And for example, in cases like that, and the vast majority of OCD cases in a frum patient will present with some form of frumkeit issue, because for whatever reason, halacha lends itself to be abused that way, and people do. So in all of those cases, which are the majority, I make it a point that I prescribe my medication, I refer them to a therapist, and I demand that they get a dayan, that they get a rav that is going to pass in the shaylas, and a dayan hopefully that understands what this is about, so that they will know that they will pass in once and that's it, never again. You're not allowed to ask that shayla again, because after the first shayla, it's not a shayla, it's OCD. So that's one example. Probably the most prominent one. In manic patients, of course, but you don't need to be a maven in Yiddishkeit to understand that. But in manic patients, when they become psychotic, inevitably, all Jewish patients that become psychotically manic are either going to end up thinking that they're Mashiach, or that they are bringing Mashiach, or that they are the mother of Mashiach, or something related to Mashiach. That's inevitable. Every single one of them. Because if you think that the presentation of psychosis in mania is basically with grandiose delusions and hyper-religious delusions, so put those two together. What is the most grandiose religious thing you can be in the Jewish world? Mashiach. So that's inevitably the reason. But that, you don't need to be a maven to understand that that is not normal. And
Do you think the average competent psychiatrist in and around New York City can effectively differentiate between OCD and actual halacha? Like, preparing for the mikveh sounds like OCD if you don't know what
Yeah.
it is.
yeah,
So do you think your average psychiatrist is as
probably
competent?
not. Probably not.
That's right.
And they would have to seriously educate themselves if they wanted
That's my
to deal
fear.
with the issue. Because where's the cutoff? Is it an hour?
Right.
Is it 45 minutes? Is it 2 hours? Where do you draw the line, right?
Right.
And of course, it's not about time. It's about what is it that you're doing and what is it that you're worried about, right?
Right.
And how do you feel after you finish doing it, right? So you clean what you need to clean, and it's clean. And if you clean what you need to clean, and no, I need to clean it again, and no, I need to clean again,
Yeah.
right?
I actually read research that secular therapists or psychiatrists were better at diagnosing religious OCD than religious people.
I don't think so. I don't think so. I don't think that's very possible.
It's not just about
Makes sense.
halacha, it goes under the Iran
Makes sense.
Yiras
That makes
Shamayim.
sense.
So that you really
Look at it
can't.
objectively.
Someone says because of Yiras Shamayim, it's one
Right,
doing
right,
beyond halacha,
right,
so it's not
right,
related to
right.
halacha.
And today, of course, this week, every other phone call that I get, and I get about 50 of those a day, is about whether the medications are kosher for Pesach. So I don't paskin, of course, and I'm not going to tell you whether it is or isn't, but there's definitely plenty of opinions that say that medication is not food, so it's not considered chametz to begin with. And even the opinions that do say that medication can be considered food and can be a chashash of chametz, if you have to take your medication, you have to take your medication. And there's different ways that people do it. Some dayanim say that you wrap the medicine in a piece of lettuce. Sometimes you wrap it in a tissue and you swallow it. But you have to take your medication. You have to take your medication. Another situation that is very common that you have to work around, or that I have to make a final decision, is, for example, regarding fasting. When is somebody allowed to fast? When is somebody not allowed to fast? From a medical point of view, if you ask a secular doctor, you're not going to be allowed to fast most of the time, right? But I have to be a little more careful in that. And when I tell people you can't fast or you can't fast, then before Tisha B'Av and before Yom Kippur, whenever possible, I try to reorganize patients' medication schedules so that they can take the medication ideally all before the tinnitus and after the tinnitus. So that's another thing that I have to work on those weeks before.
How do you do,
Well, she was first.
Yes, I just want to,
Gotta
you
speak
address
up,
for a
so
moment?
people who are,
just for a moment, if you can address PANDAS,
I'll repeat it.
the syndrome that
Uh-huh.
is often.
So about pandas. Pandas is an interesting thing. It's a controversial issue. It's not very controversial for me. I believe it exists, and because I've seen it. I'll explain it in a second. So pandas, I forget the exact acronym, but it's basically an autoimmune disorder where the immune system attacks, among other things, certain areas in the brain. The best known one are the basal ganglia, causing certain psychiatric symptoms. The concept started with rheumatoid fever, okay? That is a condition that virtually doesn't exist in the world much anymore, except in undeveloped countries, which is when people used to have multiple strep B infections, especially during childhood, that eventually the immune system would rev up and develop antibodies that would start attacking not just the strep, but different parts of the body. The main victims of this autoimmune attack were certain joints, heart valves, like there was a mitral valve condition that was typical of rheumatoid fever, and the basal ganglia. And when it attacked the basal ganglia, they developed this neurological movement disorder that's called Sydenham chorea. Okay, that is like involuntary movements, like serpent-like movements in the extremities. It was extremely disturbing and not very treatable at that point. Interestingly enough, and this is more anecdotal personally, I saw a lot of rheumatoid fever sequelae when I was in medical school in Chile. Because there it was still happening that kids were not getting treated with antibiotics. Chile, in South America, so kids were not getting treated with antibiotics properly, and there were a lot, at least in the older people I was seeing, I saw a lot of people getting their mitral valve replaced because of this. So one of the things that happened is that they saw that that people with Sydenham chorea also had OCD symptoms. Very, very typically, they would get literally like mamash OCD symptoms. So they started looking at this, and they started looking, especially in the NIMH and in other places, they started looking at patients that perhaps had milder versions of this where they might have, like OCD, for example, atypical forms of OCD without the chorea, and that might be coming from the same autoimmune reaction. And there was one doctor, I forget her name, but at that time I was working in the eating disorders unit, and she was describing certain very atypical cases of.
Susie Shulman?
No, it was somebody in South Carolina. She's the one that described it. Atypical forms of eating disorders, especially in young children. We're talking 6, 7 years old, that developed restrictive anorexia. That you couldn't explain, and that she felt might be PANDAS related. Interestingly enough, when this research was coming out during those years, we get in the inpatient unit at Cornell, the eating disorder unit, we get this little 7-year-old boy that had repeated strep B infections to the point that his throat would close up and he was vomiting all the time, and all of a sudden he stopped eating. So the logical explanation was, he's afraid of swallowing. He developed a phobia of swallowing because he would choke and throw up, and that's why he's anorexic now. Sounds nice, but I said, just for kicks, I had read the paper, let's do the blood work. And lo and behold, the blood work was positive, and I treated the kid with amoxicillin, high doses for a while, and he got better. The anorexia went away. So I was sold at that point. So I believe it exists, and I'll tell you an even scarier, in quotes, experience that I had very, very recently. And this is unrelated to PANDAS, but it probably is related in some way that we still don't know. There was a research paper about a year ago or two that used an antibiotic regimen to supplement the antipsychotic regimen for schizophrenic patients with excellent effect. And I happen to have this chronic schizophrenic patient that has been extremely difficult to stabilize on the most complicated medication cocktails, and very, very difficult. And I had him quite good. He was quite better than he had ever been in his life. Probably a 30-year-old guy. He was doing really great. And what happened? He developed appendicitis. Ended up in the hospital with a ruptured appendix, and they took it out, and they put him on antibiotics in the hospital. And all of a sudden, the guy was better than he had ever been. Even when he was being treated by me and better than ever, most of his symptoms completely disappeared. All the residual symptoms that he had disappeared completely. And he came out of the hospital, and mom anecdotally tells me, "Oh, it's so funny, he was in the hospital, he was doing so well." And I said, "Wait a minute, he was in the hospital and he was doing better?" "Yeah, and then he came out of the hospital and he's not doing so well anymore." "What were they giving him? Antibiotics." I said, "Oh my gosh." I put him back on antibiotics, and he's doing amazing. He's doing absolutely amazing.
Did they make him on his antipsychotic medication?
Yeah, he was on his antipsychotic medication, the same regimen, and the same regimen that he's now, but on the antibiotics, different person, completely different person. What's the science behind it? Don't ask me. I have no idea, but boy, it worked. So I wish we had the knowledge to be able to identify which other patients could be benefiting from approaches like this, but we don't yet. So PANDAS is a real thing. I think that it's abused, like a lot of these things. It's definitely abused. And going back to the Jewish community, there's because of the stigma and because of this desperate need of families of their children not having a psychiatric illness, and anything but a psychiatric illness is acceptable. So we see a lot of this. It's PANDAS maybe, and the new thing, especially upstate, is Lyme's.
It's what?
Maybe it's Lyme. Lyme.
Oh,
It's
Lyme.
Lyme disease. So every other patient that I get is, no, but maybe it's Lyme's. Maybe it's Lyme's. Should we test for Lyme? You know how many patients are going to test positive? If you live up in Rockland County or in Monroe, you know how many people are going to test positive for Lyme that don't have Lyme disease, have never had Lyme disease? Yeah. It's like mono. That's the other thing. Maybe it's mono, right? It's not depression. It's mono. So but I had my general doctor test me for mono, and yeah, it was positive. And the general practitioner, sometimes they're not so knowledgeable and says, yeah, maybe it is mono. No, it's not mono. How many people in the general population are going to test positive for mono? Half? 60%? More? And we were all asymptomatic, never had it. So Lyme's is the new one. It's Lyme's, it's not psychiatric, because anything but psychiatric illness, right? And it's not Lyme. Lyme, of course, there are chronic Lymes that can have neuropsychiatric presentations, but they are very, very different than a standard garden variety psychiatric condition that is easy to diagnose and differentiate.
So when you say PANDAS is abused, when it is abused, what's the risk? In other words, what happens?
The risk is
if
wasting
PANDAS
time
not-
in diagnosing and treating the real condition.
I see.
And like with any chronic medical condition, any day that you waste in treating it, the prognosis gets worse. The earlier you intervene, the more aggressive you treat, the faster the patient gets better, the better the prognosis. That's with any chronic medical illness. There was somebody over there.
Yeah, sir, I'm just gonna ask you about how do you deal with like the chicken and the egg problem? Meaning if I get super stressed out and my cortisol levels go up, right, so then my immune system is being compromised and whatever other effects.
Yeah.
How does that relate to the model that you put forth about mental illness being a problem with, let's say, some of the circuitry being messed up in the brain or something else? How do you put those two models together? The model that I can influence whatever chemicals are getting released in my brain, as well as whatever chemicals are already present in my brain are influencing my behavior. Like, what are you going to use to bridge those two ideas in a practical setting? Meaning, if somebody comes to you and let's say they just got fired from their job or something else, but this might have just been, let's say, the straw that broke the camel's back with a pre-existing condition. And how do you even know which one's which?
You just nailed it on the head. Only if you
just for the benefit of people who are
the question.
Yeah.
The question is how do you bridge the gap between a stressful event that of course is going to affect the chemistry of your body and your brain with cortisol levels and all kinds of other chemicals, and knowing that whether that's what triggered the condition or something else, how do you put those two together? Yeah. So the answer is very simple. Only if you are genetically predisposed to a specific condition will stress be able to trigger it. In other words, is it possible for stress and a stressful situation like getting fired from your job to trigger an episode of major depression? Yes. But if and only if you are genetically predisposed to major depression. If you're not, then you can be stressed out as much as you will, and you are never going to end up clinically depressed. You might be down, like in the late term of depressed, feeling depressed for a couple of weeks, but you're going to be fine. I had that situation today with a lady that came in. Her mother died, 6 months ago, right? And she's still in the midst of a profound depression that's not getting better. And she kept on fighting me and saying, no, it's because I'm mourning, and it's because my husband is giving me a hard time, and I'm not being able to mourn correctly. Well, it doesn't matter if you're mourning or you're not mourning. Any normal person that goes through a terrible loss like that and does not bounce back by week 6, there's a problem. But that's only going to happen to somebody who has the genetic predisposition for it. If not, it's not going to happen. It doesn't matter how severe the stress is going to be. Okay? You might have anxiety, because everybody has anxiety. Anxiety is a normal thing, right? We all have the mechanism for anxiety. The fight or flight response, we all need it. It's there for a reason. It's an alarm system that we all have. But you're not going to have an anxiety disorder. You're not going to have panic attacks unless you're genetically predisposed to it. And then you can throw in there, if you want to get more sophisticated, you can throw there epigenetics, right? And how the environment is going to influence your genes and the expressions of your genes and might change your genetic makeup, right? Exactly. So we know today that the environment can change your genetic makeup, and that can then be inheritable, right? And we have research to prove that children that suffer severe trauma, especially in their early years, will develop a genetic predisposition to depression and anxiety disorders that they didn't have before because of the trauma. And now that becomes a permanent chemical scar, genetic scar, if you will, in their brain. That is even worse, it's inheritable. Okay? And that, to me, when I read that, I understood all the research that shows that children of Holocaust survivors have a far higher incidence of mental health problems than non-children of survivors. And of course, the thinking up until now has been, because they were such difficult people, right? The survivors, for good reason. But that's not true. I know plenty of survivors that are the sweetest, nicest people in the world, right? And that you would never know if somebody didn't tell you. And their children still have a higher incidence of mental health problems. So how do you explain that? Well, there's your explanation, epigenetics.
But that would only present if they were child survivors.
Not necessarily. Severe trauma, even later in life, in children, it's easier to see because they're more susceptible. Their brains are malleable. Their brains are plastic and they're changing faster. But even in adults, it can happen.
You could alter the genes
Yes,
and
you
make
can.
it inheritable?
You can alter the genes.
Wow.
Read it up. Epigenetics is fascinating. Fascinating.
Yeah. I have a question.
I got a question from the live
Okay.
stream.
That one on you.
If you, let's say this patient had schizophrenic, who you put him on antibiotics, I'm assuming you're doing it for life.
Yeah.
The question was, how does it affect his immunology or his susceptibility to superbugs?
So, good question, and I have been worried about that. I happen to be using the antibiotic that they were using in the research that I had read, which is minocycline, doxycycline. That it has been, there's a lot of experience in using minocycline chronically because they were dermatologists were using to treat acne for many, many years. They've been prescribing doxycycline chronically for years and years.
So with the kids though, that's adults is one thing, but kids that's a bad look. Literally, great teeth.
Right. Okay. Fine. I don't treat children, so I don't have that problem. So with this guy, I'm using minocycline, but I'm still worried about it. And it's not so much that I'm concerned about superbugs or anything like that. I don't think that that's going to be an issue, but I am, and definitely it's not going to affect this guy's immune system. But what it will affect, inevitably, is the intestinal flora, right? And we are seeing droves and droves of research coming out these days about how your gut bacteria determines all kinds of things in your health, from cardiac health to mental health. There's more and more research showing how certain abnormalities in your gut bacteria can lead to depression and anxiety, and how using probiotics to treat that can help treat depression and anxiety. There's all kinds of chemical explanations for how that works. So I was worried about that. So what I do is I've been prescribing this guy a really strong probiotic to take together with the minocycline to try to make sure that his intestinal bacteria is preserved as much as possible.
Is addiction a psychiatric symptom, and are there any factors that affect addiction in the frum world?
Thank you. That was the other thing that I want to talk about tonight that I forgot. Yes, addiction is a psychiatric illness, and we know the basics of how it works and how in certain genetically predisposed individuals, once you activate the reward circuits in the frontal cortex of the brain, once you open those pathways, it's like you build a superhighway. And once you build that superhighway, closing it up is extremely difficult. That superhighway is open for circulation, and it's open for life. So once somebody who's genetically predisposed to addiction, once this reward circuits in the brain are opened up, they're there, okay? And that's how we know that addictions are addictions, and that it doesn't really matter what your fix is. Doesn't matter if it's a certain drug or alcohol or gambling or sex addiction or whatever it is. Whatever that thing is, your fix that gives you that dopamine high, okay? That's what you're going to be looking for, and you're going to keep looking for that dopamine high. That is, so in other words, what people are really addicted to is not that drug or that alcohol or that gambling. What they're addicted to is the dopamine rush in their brain that thing happens to trigger. And that's why you see very often that people go from one addiction to the other. Because it's not about that thing, right? Not about cocaine, it's not about alcohol, it's about what's happening inside my brain every time I use that thing. And closing that up is extremely, extremely difficult. And we don't have really great ways to treat it right now, but there's some movement in the field. There's definitely some movement. There's certain medications right now that dampen the reward effect of whatever your fix happens to be. Like naltrexone, for example, is one good example of that. We see now that you give it to an alcoholic, right, and then they drink, and all of a sudden they are much better able to drink moderately than before, because they taste the wine, and that rush that used to happen in their brain is not happening anymore. So it's like they drink and it's like, ooh, this is boring.
And they're compliant? Like they're fine
So
with that?
that's the question. That's the question. Some are, some aren't. There are even long-acting injectable versions of naltrexone, right? Vivitrol, you can give once a month injection. I have a couple of patients that come to my office. I give them a shot once a month, so at least I know they're getting it. And it's not the be-all and end-all of the treatment. Of course, the psychotherapy of it is extremely important also. And to teach these people how to find their kicks in healthier ways in life. And usually by the time they get to treatment, they have devastated their lives in such ways that it's very, very hard. We have a huge problem with addictions in the firm world. Huge. It's enormous. I mean, you read the numbers and they're absolutely staggering.
Would you say more so than in the secular world?
No. But what's changed? Absolutely not. But what's changed? It's probably less than
More
the
so than
secular
it
world.
used to
But,
be? More so than it used to be?
that's what I was going to say. It's more than it used to be. It used to be. It used to be that addictions were a very marginal thing in the firm community, and over the last probably 20 years or so, it's skyrocketed in a frightening way.
Maybe it was just underreported.
Some of it was, and some of it still is. So if we added today the numbers that are being underreported, which are probably huge, that it would be even more staggering than it is. But there are certain numbers that we do have that you cannot cover up. And the hundreds of firm kids that have died of overdoses in the last year or two. I mean, I forget the number, probably because I wanted to forget it. But it was like 100 dead kids in a year last year. That's an insane number. 100 dead kids from overdoses, opioid overdoses, and the ones that are abusing opioids are the fewest of all the addictions, because to get to opioids, you really need to work your way up the ladder in the career of an addict. I mean, it's not, you don't get there you don't start with opioids.
You broke your leg and somebody decided it's a good idea to give you oxycodone 14
True.
a day.
There are more and more of those. There are more and more cases of that.
Die a little bit as though
It's happening more and more.
Isn't that just because they're cutting with fentanyl?
No, not only because that makes it worse.
In regards to
Plain old Percocet.
In regards to deaths, you're saying?
This comment, meaning that the fact that it could have been underreported, now it's getting more attention because people are dying because of fentanyl, but that doesn't necessarily mean that the prevalence has increased or decreased, right?
The prevalence has increased. I mean, to have the deaths, people need to be getting addicted, right?
Well, I'm saying it could have been that they just weren't dying beforehand because the heroin was less dangerous.
No, that's not how people died in general. In general, the vast majority of the deaths are not. The vast majority of the deaths are not because you bought a bad batch of fentanyl. The vast majority of the deaths happen because people with opioids, it really builds up tolerance very, very quickly. Whatever it is that you're using, heroin, fentanyl, whatever it is, it builds up tolerance very, very quickly. And these are mostly people that are trying to quit. So they go to rehab, and they go to detox, and they get detox, and they haven't used it for a little while. And then when they go out and they relapse, they go back to the last dose that they were using, and their bodies are not able to use anymore. Their bodies don't tolerate it, and they die. You understand? So a lot, if not most, of the deaths are happening because of that. There have been some deaths related to really bad batches of fentanyl and heroin too, that have been cut with elephant tranquilizer and stuff, that have killed a lot of people. Most deaths are happening to people that are out of rehab, and then they relapse and they make the mistake of thinking that they need the same amount they were using before. But that doesn't matter. The point is that people are using it and people are dying, and it's large numbers of people that are dying. And those are the most extreme cases. So, like she's saying, what about all the cases that are under the surface? What about all the milder cases? And there's a lot of those. A lot.
How do you get good data on the community specifically?
It's not easy because there's not a lot of research being done. So it's mostly the pulse that you get from just in and out, day in and day out, sitting in your office and seeing what's going through in front of you. But to have accurate numbers, we don't have. And we can't have because, again, going back to the beginning of today, stigma. What school is going to let you go in and do a survey on how many kids are using what? Which school is going to let you do that? Huh?
Also, a lot of kids that are using aren't going to be in some schools.
Yeah.
They're going to be kicked out of the system in whatever capacity
Exactly.
that they are.
And how many schools are going to be willing to report how many kids they've kicked out because of drug use? So how do you study this? There's got to be a way. To understand if there was a will, there would be a way, but there's definitely no will. and this guy, I forget his name, Zvi Gluck of Amudin, that's working really, really hard in the whole Indian of addictions in the film world. He's really, really trying really hard and to educate people and talking and writing. And he goes to schools and he tries to say, let me talk to the guys. Let me talk about addictions. Let me do some prevention. We're not going to be the school that has the drug use that have Zvi Gluck speaking for them. Of course not. You're not. You're not the school. There's nobody using drugs in the schools. Certainly not. Chas v'shalom. What are you going to do? If there was less stigma, we would be able to be a little more open about it. Somebody over there was asking a question.
What percentage do you think the patients that are treated for generalized anxiety disorder or major depressive disorder will be on lifelong medication? Even like once they're feeling better, is there times you would take them off?
That's a great question. The question is, two examples, generalized anxiety and major depression, how many of those are going to be on medication for life versus how many are going to be able to go off their medication? Both generalized anxiety and depression are chronic illnesses, okay? Like most psychiatric illnesses, these are chronic conditions. They're not going away. The best example is to compare it to high blood pressure, Crohn's disease, diabetes. That's what you're treating here. So just like with high blood pressure and diabetes, there are some milder cases because the genetic load is milder, because for whatever reason the condition didn't develop into something more severe, that are going to be manageable without medication, right? It's not that the condition went away, is that it's milder and it's manageable. So those patients might be on medication, those patients with generalized anxiety might be on medication for a year or so, and then they will go to CBT and learn to handle their anxiety with the different CBT techniques. And you'll be able to take them off medication for a while, and eventually they might need to go on another round of medication for a year or so. It's possible.
What I see is when patients come to me, I work in Monroe, and they can't afford a psychiatrist follow-up all the time because a lot of psychiatrists do not accept insurance.
Yeah.
So they come to me as a primary care.
Yeah.
At what point do I refer them back to psychiatry if they're on it for 5 years and they're doing fine, and I'm refilling their prescriptions for that?
So let me finish my answer, and you'll understand better. but those are few and far in between, those cases, those mild cases that might be able to function without medication. The vast majority of people with generalized anxiety disorder will have to stay on medication for life. The vast majority. I would say 80 to 90%. With depression, the situation is similar but slightly different because depression is an episodic illness. At least initially, it's episodic, right? So there are flare-ups, and somebody will have an episode of depression. It will, if you don't treat it, it will last for 6 to 8 months, and then it will remit spontaneously. But over time, with every new episode of depression, the next episode will become sooner, more severe, and it will take longer to remit. Okay? And eventually it reaches a point where it never remits fully. And it becomes very, very severe and untreatable. But potentially there are some patients with depression that you could treat, and usually the standard of treatment is once the patient is completely symptom-free, you stay on maintenance for 6 to 8 months, and then you taper them off over a couple of months. So the Ganze Parsha is about a year. And then they'll stay well for a period of time. Could be a year, could be 5 years. But eventually they will have another episode. And then you treat them exactly the same way, again for a year, and then stop, and so on. But there are patients that once you try to taper them off, they will fall back within a couple of months. And those are the patients that are going to have to stay on medication for life, and that's probably, I would say, 40 to 50% of patients with depression. Less than with generalized anxiety, but certainly a significant bunch. With a patient with generalized anxiety, what I would tell you is, do the same. Treat them for a year, year and a half, 2 years maybe, and then try very, very, very slowly to taper them off the meds and see what happens. Chances are, the patient's going to come back begging for you to put them back on their meds and just leave them alone. Forget about it. There's no reason to have somebody suffering.
Would you go straight back up to their dose, or would you gradually?
You always titrate up because to avoid some of the side effects at the beginning, but yeah, you get them back to the dose that got them better last time. You're not going to get away with a lower dose. Sometimes for long-term maintenance, you might get away with a slightly lower dose, not dramatically lower. But to treat them, you always go back to the same dose, and probably sometimes higher. The first episode, there was somebody here.
Yeah, I had a question.
Yeah.
The pandas case that you said with the guy in the hospital, does pandas happen to adults? And also, if so, why not just give everybody a course of antibiotics first to see if that's the whole thing?
Yes, pandas can happen to adults, less often than with kids, and no, we don't just give people medication because we give medication if there's evidence to support the idea of using that particular medication in this particular case. Not every psychiatric patient is a pandas case. This is a fraction of patients that we're talking about. So we absolutely shouldn't be treating everybody with antibiotics and, like he said before, creating superbugs that are going to come to destroy humanity. No, that's never a good idea. Yeah.
Someone's asking on the chat if you can discuss like herbal supplements for milder conditions.
Herbal supplements for milder conditions. They're asking somebody online. Good question. There is research on certain vitamins and supplements. Like for example, there is plenty of research-based evidence for the use of certain types of omega-3 fish oil supplements in depression and anxiety. There is research on the importance of vitamin D supplementation. That's very important to the frum community because the vast majority of the frum community is vitamin D deficient, and vitamin D deficiency can contribute to anxiety and depression, and it might make it more difficult to treat the anxiety and depression if the vitamin D is not supplemented. I test vitamin D in virtually all my patients and supplement it when it's missing. A supplement called SAMI also has been proven in research to help with anxiety and depression. What else?
When you're listing these, are these alongside traditional medications?
So the thing is that for an extremely mild case, you might be able to get away with just the supplements. Truth is, I'm still waiting to see that very mild case. I don't think I've seen it yet. I'm still hoping. But I do recommend the supplements to a lot of people that are interested in supplements together with the medication, because it might make it the treatment faster. It might make it easier. It might make it that we can get away with lower doses of medication, and besides, it definitely cannot hurt. At best, it can help. So I have a list of some of this, that all the ones that have been proven in research, I have it printed, and any patient who's interested, I just give it to them, and off you go, happily. There are some supplements, by the way, that can be extremely dangerous together with the medications that we use, like 5-HTP. 5-HTP can, together with an SSRI, can trigger a serotonin syndrome. So it can be extremely dangerous. So any patient who's taking a supplement or interested in taking a supplement together with psychiatric medication, they need to check with a doctor before they take it. Because there are, like there's a very famous vitamin supplement in the firm world, because it's a firm company, Zallers, that they make this Mastermind supplement, right? So everybody wants to take Mastermind. Mastermind together with an SSRI can kill you. Okay? So it can give you a serotonin syndrome and kill you. So don't. And don't let your patients take it. Wait, there was somebody over there that asked a question.
Yeah.
Yeah, you were.
What resources are available for Orthodox psychiatric providers, or like the overlap of, Judaism and psychiatry, like books or groups or conferences?
Nefesh. Nefesh is the best. Nefesh is the organization of Orthodox mental health professionals. I don't know if they have research published. If you find anything published, let me know. I don't know of anything. But definitely Nefesh has a great conference every year around December time. Yeah, they have a listserv where they talk about things. So Nefesh would be the best resource. Somebody over here, I think, was asking something.
Question. Just a little different topic. You were talking about psychotherapy that you did learn it.
Yeah.
It doesn't seem like you use it. Do you use it? Would you ever think about it?
Why
did you learn it if you got it?
I was very interested in psychotherapy early in my career. I am fully trained in psychoanalytic psychotherapy. That was the main psychotherapy that I used to do. I'm fully trained in CBT and in DBT. I've started CBT and DBT programs, even in other countries. I did a lot of therapy early in my career. But then all of a sudden I decided that I wanted to be a doctor, not a therapist. And that's what I did today. A lot. Would I say most? Maybe. Maybe I would say most, but definitely a lot. 50 to 70% of my patients, I refer to therapy for different reasons. And I have a huge network of different therapists that I trust. There's a lot of therapists that I don't trust, but there's also a few that I do trust. And I know which one is good at what, and I know how to direct my patients to the type of therapy that is indicated for them, because not everybody can do everything, and different techniques in psychotherapy are indicated for different conditions. But yeah, like I was saying, virtually every single patient that I see with an anxiety disorder, I will refer to therapy. Every single patient with a personality disorder, I will send to therapy. With depression, it varies. Sometimes yes, sometimes no. It might be helpful, it might not be necessary. It might be just take your medication, you're going to be fine. Bipolar disorder, for example, therapy can be helpful in helping the patient accept their diagnosis and their need for treatment and work out whatever issues that is bringing up in their lives. The fact, whether it's self-esteem or whatever it is that's bothering them, because about accepting the fact that they have such an illness and that they need to be in treatment, that might be helpful. Schizophrenia therapy can be helpful, for example, with certain social skills and behavioral modification, and helping them be better at interacting with people. Autism, the same. High level of autism, like Asperger's syndrome type. I have a couple of therapists that are outstanding at getting these guys at learning how to read social cues and interact with people in an amazing way that they would be able to do without it. So if it can be helpful, I am very ready. And because I am fully trained as a therapist, so I understand when therapy can help, and I know how to indicate it. And I also think that having been a therapist for years and knowing how that works makes me better at what I do, at managing the interaction with the patient and getting them to take their medicine. So it can be helpful. Almost every time that I see a patient, when I see that there's a need, I'll throw in a little psychotherapeutic intervention if needed. But yeah, at some point I decided that I really went to medical school because I wanted to be a doctor.
But most psychiatrists learn psychotherapy?
Not anymore. It used to be, yes. Now they learn like the basics, sort of to let them know what psychotherapy is about. But not anymore. They don't get trained in psychotherapy.
What percentage of the general population have a diagnosable disorder? What do you say?
I would say probably, if you add it all up, probably around 20%, maybe 25.
10 people in this room.
There's about a 10% incidence in the general population of depression. There's about a similar incidence of anxiety disorders.
They're different people?
Sometimes not. And then the major psychiatric disorders like bipolar, schizophrenia, and the like, those have a very small incidence, 1-2% of the general population. And then eating disorders, maybe we're talking about 2-3%. So addictions is much higher incidence. So if you add it all up, yeah. Rabbi Tursky, Avram Tursky, once was giving a lecture. He was talking about shidduchim and psychiatric medication, and he said to the room, he said, half of this room right now is either taking psychiatric medication or has taken psychiatric medication or will take psychiatric medication at some point in their lives, and those are not the ones you need to worry about in shidduchim. Yeah, it's the other half that should be and is not. Those are the ones they need to worry about.
Would you say that, like, if you had preemptive therapy or like some kind of mental building, meditation or whatever, same way like a person who works out or eats healthy is, you know, more predisposed to have a healthy lifestyle. So could that prevent mental illness, you know, build mental health?
In the milder cases, when the genetic loading is smaller, right? And whatever other insult to the brain, like unduly stressful psychosocial situations, are not present, then the answer would be yes. Definitely having a healthier brain, including meditation, exercise, healthy diet, healthy spirituality, social connections, etc., sure, it can be prevented. If the genetic loading is big enough, then it's going to happen no matter what you do. It's like having high blood pressure, right? So
doesn't diet mitigate that?
So when I was diagnosed with high blood pressure, I was 35, and my doctor told me, okay, you need to lose. I was not very healthy at that point, and he said you got to lose 20 pounds, and you have to eat healthy, and da 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 da. I did all that and more, and I work out regularly. I lost my 20 pounds and more, and I eat ridiculously healthy, and I still have it. So guess what? My grandmother had it. My mother has it. I didn't stand a chance, but I still make sure to keep my healthy habits because it's going to help manage my high blood pressure much better than otherwise. Interestingly enough, with children is a little bit different. With little children, like if you catch an anxiety disorder, for example, in particular, an OCD type condition, early on, we're talking 3, 5, 6 years old, with therapy, with a therapy intervention, and there are very specific therapy interventions at that age, because the brain is still plastic enough, you might be able to reverse the predisposition. The kid might always be somewhat on the anxious side and on the OCD-ish side, like people talk about that, but it might never develop into a full-blown condition if the intervention is early enough when the brain can still modify itself.
I mean, you don't want to tell parents about that because then they'll get OCD about watching if their kids.
But you have to, and I tell parents, because my patients, of course, their kids have a slightly higher risk for it. So if a patient tells me, oh, I see my 5-year-old is starting with this stuff, it's like, listen, get them to therapy ASAP, and get 6 months of therapy might save you a lifetime of pain and suffering.
All right. I'm going to take one more and that's it.
Along those lines, earlier you were mentioning how with children that suffer trauma early on in life are able to develop genetic predispositions.
Yeah.
So could like intensive therapy at an early age, you know, soon after exposure to trauma?
Yeah, of course. And so the question is if early trauma can induce a genetic modification that predisposes the patient to psychiatric conditions like anxiety and depression, can an early intervention like therapy bring it back down? And the answer is yes. An early therapy intervention in childhood, when it's well done and early enough post-trauma, can absolutely prevent serious problems down the road. Absolutely. Maybe it's not going to prevent it 100%, but significantly modified. Because the brain is plastic. At that age, the brain is still plastic. Our brains are they're stuck. It is what it is. They're only dying slowly. But in children, when their brain is still growing and developing, then you can do tons of stuff.
All right. Thank you very much.
Pleasure.